Hello, and welcome to CRPS Contender, my complex regional pain syndrome education channel. Today's video is Complex Complications, and we will be taking another step down our journal journey. In our journal journey series, we are exploring the published literature surrounding CRPS so that we can have a better understanding of the mechanisms and underpinnings of the disorder, as well as which treatment options are viable and appropriate for CRPS so that we can make informed and autonomous decisions regarding our health and well-being and the reduction and management of our symptoms while living with this debilitating condition. The paper we're exploring today is Complex Regional Pain Syndrome, Systemic Complications, written by Schwartzman and published in Practical Pain Management in 2013. Let's take an overview. It has been generally accepted that over time, CRPS affects the somatosensory, autonomic, and limbic components of the pain matrix in a majority of severely affected patients. The systemic complications of the syndrome, however, are not as well appreciated. The pathophysiology of the disease includes peripheral sensitization of the small and unmyelinated or thinly myelinated sensory nerves in the area of injury, central sensitization of the pain transmission neurons in all components of the pain matrix, immune mechanisms, and a maladaptive response of physiologic pain mechanisms. This review focuses on the severe subtype of the condition, which is manifested by pain that is spread from the original site of injury, is long-standing, comprises all components of the syndrome, and may be generalized to the entire body. Now, if you would like more detail regarding specific numbers of the studies that he is summarizing in this paper, of course, the actual paper will be linked below. You can go and check that out. Because there were so many numbers in his paper, I am just using the percentages. Starting with neuropsychological deficits, we do have a mini-series in our Journal Journey series regarding this specific paper, so you can go ahead and check that out if you want to. Researchers noted 3 distinct groups of neuropsychological deficits in CRPS patients. Neuropsychologically normal patients, which were 36% of the cohort, patients with mild dysexecutive deficits, which was 42% of the cohort, and patients who had cognitive impairment in executive function, naming, and memory, which was 22% of the cohort. Evidence suggests that the memory dysfunction is related to retrieval rather than encoding of memories. Patients demonstrated activity-dependent neuroplasticity, with a clear alteration of the patient's hand representation in the primary somatosensory cortex, which reverted to normal with recovery from the disorder. Patients demonstrated tactile and proprioceptive deficits and also reported as if their hands felt foreign or strange or not belonging to their bodies. In addition to the impaired cognitive function and plastic aberrations of the body schema demonstrated in CRPS patients, there may also be structural brain changes. Now, this paper was published in 2013. In the decade since, yes, we have proven that there are structural brain changes in CRPS patients. Constitutional symptoms. Almost all severely affected CRPS patients complain of lethargy, tiredness, and weakness. As the illness progresses, there is an increase in pro-inflammatory cytokines in the serum and cerebrospinal fluid and a decline in all anti-inflammatory cytokines. The initial nonspecific immune activation following injury or infection occurs within hours and is called the sickness response. The severe fatigue suffered by the majority of CRPS patients at all stages of their illness may result in part from the engagement of this sickness response circuitry. Regarding chest pain. The cause of atypical chest pain in CRPS patients, which is more frequent in women than in men, is irritation and sensitization of the intercostobrachial nerve. A recent prospective study evaluating the sensitivity of the chest wall in CRPS patients and in normal controls revealed that the majority of patients with upper extremity CRPS reported a history of chest pain, 94% of them did, compared to 19% of controls. Of the CRPS patients with chest pain, 66% had bilateral pain, 79% reported pain that was above the breast and deep in nature, 51% of patients had pain that radiated to their jaw, head, or neck, and 46% had shoulder or arm pain. In 65% of the patients, chest pain was elicited by elevation of the arms. Cardiac complications. There were no specific EKG abnormalities in CRPS patients, other than a slightly higher than normal pulse rate ranging from 80 to 100 beats a minute. The ejection fraction ranged from 50 to 65%, not differing from controls. Approximately 10% of this cohort described palpitations, syncope, which is passing out, or pre-syncope, which is feeling like you're going to pass out, during the course of their illness. CRPS patients were 4.5 times more likely to have a positive head-up tilt test result. Lower extremity CRPS involvement was more likely to precipitate vasovagal syncope and a positive head-up tilt test rather than upper extremity or total body disease cases. Lower extremity CRPS patients also have an enhanced predisposition to neurocardiogenic syncope during the head-up tilt test. When evaluated during rest, mental and orthostatic stress increased the heart rate, as well as a decreased heart rate variability with normal baroreceptor sensitivity. CRPS patients also demonstrated a drop in cardiac output and an exaggerated increase in total peripheral resistance that correlated with the duration of the disease but not with pain intensity. It can be concluded that the increased heart rate and decreased heart rate variability were measures of generalized autonomic dysfunction. Respiratory complications. CRPS patients often complain of not being able to take a deep breath. Dystonia in the chest wall muscles is common. Dystonia in CRPS occurs more regularly in younger patients with a longer duration of the disease. Chest wall dystonia can affect respiratory muscles and cause restrictive lung disease. Inspiration, or the inhalation of a breath, activates the sensitized intercostal brachial nerve, causing a nociceptive guarding reflex of the pectoral and intercostal muscles, which is your chest and in between the ribs. Moderate to severe CRPS with an involvement of 2 or more extremities revealed shortness of breath in 16% of patients, complete or partially collapsed lung in 33% of patients, and low lung volumes in 17%. Autonomic dysregulation. Peripheral autonomic manifestations of CRPS are frequently misdiagnosed as Raynaud's disease, particularly if the affected extremity is minimally painful. In older patients, CRPS is often confused with fibromyalgia or vascular insufficiency. Warm extremities are often thought to be infected. Fainting or feeling like you're about to faint from failure of the compensatory reflex-induced increase in heart rate when your blood pressure falls is seen in approximately 25% of CRPS patients. For those with CRPS of less than 4 months duration, the affected extremities are often warm and demonstrate higher skin perfusion than the unaffected areas. However, in patients who have had CRPS for longer than 2 years, the extremity is usually cold. CRPS patients demonstrate an upregulation of Neurogenic receptors or an increase in their sensitivity on blood vessels that may increase their responsiveness to circulating norepinephrine from the adrenal gland, resulting in vasoconstriction. Vasomotion, the sympathetically mediated wave-like fluctuation in the veins that help your blood get back to your heart, is reduced or absent in CRPS patients, manifesting as dilated veins. Neurogenic edema, or inflammation. An abnormal inflammatory response to tissue or nerve injury that does not abate with healing is common in CRPS. For patients with at least 1 year of duration, 75% exhibited neurogenic edema, which is caused by nerve signaling. That percentage rose to 90% after 15 years duration. Swollen body parts are often simultaneously red. Neurogenic inflammation is often mistaken for an infection or thrombophlebitis, which also may occur simultaneously. Musculoskeletal System. CRPS patients report loss of strength, difficulty initiating movements, and atrophy of the affected extremity, with percentages at 70%. Muscles from amputated limbs of 14 long-standing CRPS patients revealed fatty degeneration, muscle fiber atrophy due to oxidative damage and glycolytic damage, neural degeneration, and reinnervation. Muscle in CRPS patients is hypoxic, meaning there is not enough oxygen, and consequently fails to maintain a normal redox state. This phenomenon causes an increase in the production of reactive oxygen species, causing a lot of muscle cell injury due to oxidative stress damage. Evidence also reveals decreased activity of mitochondrial complex number 2, with a resulting decreased energy production and an increased free radical production, which contributes to oxidative stress. These dysfunctional mitochondria appear to be mechanistically involved in the muscle pathology of CRPS patients. CRPS patients also suffer deep bone and joint pain. Imaging reveals bone lakes. There is demineralization around joints, in the spongy bone, and around the outside of the bone where the nerves and blood vessels that feed the bone are. There is bone reabsorption, where the bone is being broken down faster than it's being replaced, occurring from activated osteoclasts and possibly due to nociceptor release of substance P. This postulated pathophysiology would decrease the pH enough to also depolarize the dense pain nerves inside the bone. Bone formation and maintenance are dependent on small fiber innervation, and remember, those small fibers are being damaged and are dysfunctional in CRPS. Fractures occur during usual activities of daily living or with minimal trauma, and they heal poorly. Frequent sites of pathologic fractures in CRPS are the fifth metatarsal of the foot and the distal ulna. Dermatologic manifestations. Approximately 71% of CRPS patients of at least 5 years disease duration suffer skin manifestation. This percentage increases with disease duration, with more than 80% of patients who've had CRPS for at least 15 years having skin manifestations. Dermatologic manifestations of CRPS include a red butterfly rash on the face, often mistaken for systemic lupus, mottling, cyanosis, which is blue coloring, redness, which can often be mistaken for Raynaud's disease, 1 to 3 millimeter punched out circular skin lesions, thought to be an insect bite, ligature signs, which look like strings that have been tied around a swollen body part, and spontaneous bruising. During the course of the illness, the skin becomes atrophic and shiny. Nails become ridged, thin, and break easily, and there is muscle and integument atrophy. Patients also have simultaneous venous stasis, cellulitis, and ulceration. Patients with long-standing severe CRPS demonstrate muscle atrophy, thickened capillaries, as well as C-fiber and nervi vasorum degeneration. Nervi vasorum are the nerves that run on the walls of the blood vessels to control them and help them also be healthy and filled with nutrients. Although in the early course of the illness, when pain may be sympathetically maintained, the hair can become thicker, curlier, and grow more rapidly. However, as the disease progresses, hair is often lost. Sweating abnormalities are reported in approximately 30% of patients. Urological system. Urological dysfunction occurs in approximately 25% of CRPS patients, and this includes increased frequency and or urgency of having to urinate, as well as the inability to initiate voiding or incontinence. Pelvic, penile, and perineal pain is prominent in CRPS patients, particularly if both lower extremities are affected. Urological symptoms are often associated with gastroparesis, which is paralysis of the stomach. Gastrointestinal system. The most common gastrointestinal symptoms were constipation in 41% of patients, nausea in 23% of patients, vomiting in 11% of patients, intermittent diarrhea in 18% of patients, indigestion also in 18% of patients, IBS in 17% of patients, and dysphagia, which is difficulty swallowing, in 18% of patients. GERD was seen in 73% of patients. Gastroparesis, or paralysis of the stomach, frequently occurs in CRPS patients with long-standing disease of usually longer than 5 years. Most often, these patients with gastroparesis have pain over much of their body, meaning it's generalized, where pain affects the lower extremities more than the upper extremities. The most frequently associated complaints are feeling full earlier than one would expect, bloating, constipation, diarrhea, IBS, upset stomach for no apparent cause, and cyclic vomiting. There is accumulating evidence that C fibers and the thinly myelinated A delta fibers, which are involved in the somatic manifestations of CRPS, may also be involved in the internal organs in the GI tract. In conclusion, CRPS is becoming a great imitator in pain medicine. It is clear that while there is a gamut of CRPS-associated problems for the various subtypes of patients, one particular sign or symptom may predominate certain patients' conditions. The process spreads, and in a significant proportion of patients, becomes generalized in the whole body over time. The visceral and internal organ involvement may be the most troubling aspect of this disease. Thank you very much for watching. If you would like to support the work that I'm doing here, I have a Patreon or a PayPal available if you would like to financially contribute. I also have a website, crpscontender.com. Thank you, Emily Malcontent and W for Shep, for your continued support. If you would like to see the notes I took, have access to the slides, or see the paper for yourself, the sources are going to be linked in the description and you can check that out. Thank you very much for watching. I hope you learned something today, and I hope to see you next time.